much for joining us tonight, everyone. We are very, very lucky to have Hannah Conway with us again to give what I think is going to be a really useful talk for us on the summative assessment process for FUSIC HD and fTOE. I think if you're prepping for those, you're far along your journey, that you're probably very familiar with Hannah, but nonetheless, it'd be rude of me not to completely hype her up being as amazing as she is. So she's a cardiac ACCP and associate professor in advanced clinical practice working in Leicester. She herself is a level 2 BSc TTE and TOE accredited. She's the national lead for FUSIC Heart. So even if you've not been to one of her phenomenal talks before, you've almost certainly seen her name under a FUSIC Heart certificate when you finally finished it. She sits on the FUSIC HD committee and she's the co-director for G&O's Critical Care Echo. She has beyond amazing level of echo knowledge, expertise and teaching, and we're really lucky to have her talking with us again at TOTEM today. Just to remind everyone while we're doing this, if you could please make sure your microphones are off for the duration of the meeting. You're very welcome to have your cameras on. Do not feel the need to do that. This meeting is being recorded so that people can see it afterwards. If you have questions as it goes along, if you chuck them in the chat won't be visible in the recording, so please don't have any fear of posting questions and so on in there. We'll be doing a Q&A at the end, but if you have a question as we go along that you really think needs to be looked at that point, just flag that in the chat and I will bring it up to Hannah. And if everyone is happy with that, shall we get started?
Good with me. Thank you, Simon. That was a really nice introduction. I never get used to those, but I'm just little old me, and ultimately all I like to do is make sure that people feel adequately prepared for these examinations, because I am one of the examiners that you will meet on the day if you're having it this year. And ultimately, as I go through this talk, you'll realise everything we do is there to try and ensure that you gain success at the end of the day. So today's session is going to be more of a specific purpose, which is ultimately to give you some practical guidance and tips on how to approach this exam, and also the time that you've got between now and the exam. You can apply a little bit of strategy to try and optimise your chance of success. So we'll go through all of that, hopefully in the next sort of 45 minutes or so. In terms of objectives, I want to walk through what I would, the three-part process that we apply to both the Focus TOE and the FUSIC HD exam, because it's common to both exams, which is quite helpful if you are going through one of these exams and want to then go on to do the other module at a later date in time. Understanding the format, I think, is half the battle when it comes to preparing yourself for these types of exams. So we'll go through that in fine detail. Second, we're going to talk through the logbook requirements. Any exam that is new tends to go through iterations, and therefore there is probably some older guidance still lingering around online. So I've pulled out the most recent guidance, the one that we're working to as examiners, and therefore you'll get an insight into what the sort of most up-to-date expectations are. Third, we're going to tackle the MCQ. Now, this is, again, a relatively standard approach across both exams, but there is some differences to how we actually approach them between the two modules, and I'll explain that in detail. Fourth, we're going to talk about the practical exam. Now, obviously, it's not a practical session, so I can't take you through how that exactly will work practically, but I'll tell you what we're looking for as examiners and how you can perhaps enhance your performance. And fifth, and most finally, I'm going to talk about some strategic preparation that you can put in place within the sort of final days or weeks moving up to the exam, because we're approaching that date soon. And hopefully, if you feel at that point now where you're ready kind of from a practical perspective, but you're not quite sure what to do with that time between now and the exam, this particular section will be for you. So where are we now? Well, we are not that long away from the Focus TOE exam at all. In fact, it's on the 6th of November. And the FUSIC HD exam is on the 14th of November. All of you that are taking the exam will already know this, because you will have put an expression of interest in, and you will already have submitted your logbook for admission to exam. Now, the ICS will have reviewed very sort of preliminary review of your logbook, just to make sure all the components are correct and suitable, and they will then essentially confirm that you are ready to have the exam, in terms of being able to have your logbooks reviewed. Doesn't mean that your logbook has been reviewed and passed. It just means that everything is there ready for the examiners to assess it. And I'll talk to you a little bit about what we do in the event of components not being passed, because it's not a case of all 3 components need to be passed on the day. If one component isn't passed, there is an opportunity to resit that component without having to do the full exam again. And we'll talk about that toward the end of the presentation. So now, in terms of the actual structure that we talk about, the logbook itself will be pre-exam submission, as I've alluded to. Now, some of you, I don't want you to worry if you haven't already handed in your logbook, because I appreciate there are a couple of cases where people have put an expression of interest in slightly later, and as a result have had a little bit more leeway on their submission of their logbook. We try where possible to be flexible, because we understand that you're all working clinicians and allied healthcare professionals. So we do try to work with you as much as possible. But the general rule of thumb is that you should be handing in your logbook around about 6 weeks prior to the exam. On the day itself, we tend to do the logbook check, although if we're particularly ahead of ourselves as examiners, we may already review the logbooks ahead of time. Obviously, we're busy clinicians and professionals ourselves, so it is very much dependent on our ability to cordon off some time. But on the day itself, if your logbook hasn't already been assessed, it will be assessed during the day, usually during the time that your MCQ is happening. Now, the MCQ itself, I think a lot of you on the call are probably from a medical background, although again, I don't know everybody by name. So this is not the first rodeo in terms of exams, and you know how these exams, generally speaking, are conducted. They are multiple choice and they are single best answer as in terms of format. The observed practical exam is how you would imagine, and as an overview, there will be either a live model demonstration for your FUSIC HD, and then obviously for the clear reasons, there will be a simulated scan for the Focus TOE. And again, as I said before, if you fail one component, you get the opportunity to resit that on a separate day. So let's look at that in more detail, because that was a broad overview. The actual FUSIC HD logbook, to start off with, is 50 cases. And for those 50, you are expected a minimum of 20 to be directly supervised. And that is, what we mean by that is that they have to be directly observed by your ICS approved FUSIC HD trainer. And there's a critical point here that tends to trip people up, and that is what constitutes normal studies versus the rest of your logbook. What we say is that no more than 10 of your cases can be normal studies, i.e. by the end of the point in which you've assessed the full data set, you've essentially summarized that this is a normal study. Okay, we want at least 40 of your 50 scans to demonstrate pathology. Okay, why do we do that? Well, hopefully it's obvious to you. It's a hemodynamic module. It's designed to assess your ability to integrate ultrasound findings, and therefore if you are essentially looking at normal studies, you're unable really to practice in the clinical context in which this accreditation demands. So that is why we, across all FUSIC modules, have stipulated that the large majority of your cases need to have pathology. Your logbook must also demonstrate proficiency across those 10 clinical questions that you should all be very familiar with. For those of you who may be coming here not having gone through the process already, but just want to learn a little bit more about it, those questions are predominantly based around ventricular function, whether it's impaired, dilated for both left and right heart, if there's any significant valvular pathology, if there's any pericardial fluid, if there's any left atrial enlargement or elevated left ventricular filling pressure. And then we focus around fluid responsiveness and venous congestion, with a little bit of aortic pathology in there. So across those spectrum of questions, you've done a full hemodynamic assessment of a patient that would be seen in acute or critically unwell setting. And every case that's in your logbook should address those questions explicitly. It may not be that every single area of those questions show pathology, but you must address them or attempt to address them across your logbook. And if your reporting is vague or selective, that's something that we pretty much pick up on very quickly. Now, your competency documents, which you, again, are common to both HD and Focus TOE, must be signed off by your approved trainer, and they must be submitted to the FUSIC portal before the assessment day. If that hasn't been done, that's one reason why you won't be put forward for the exam. So that's HD. In terms of Focus TOE logbook, it is, again, a total of 50 cases. However, there is a caveat. If you have already completed either advanced transthoracic accreditation or even focused transthoracic accreditation, that being FUSIC Heart, what was then FICE, FEEL, BSc level 1, then you will be able or eligible to take a logbook of 30 Focus TOE cases. You do, however, have to evidence that you have completed that accreditation, and it does not suffice for you to just attend a course and then use the course certificate as evidence. So you must provide us with the accreditation certificate as evidence. Now, obviously, for those of you who've done FUSIC Heart, it's easy for us to see that from our end, but we won't obviously have access to the BSc database, for example. Your logbook must include all 8 standardised views across Focus TOE, and you need to demonstrate an appropriate case mix. Again, it's not specific around which specific cases, but there needs to be an appropriate case mix across what you would, generally speaking, want to demonstrate the curriculum through. So use your initiative in that respect to have a look at the actual curriculum itself and think, does my case mix represent that? And we use a slightly different metric. We say no more than 50% of your cases can be normal, okay? Ultimately, we want to see that you have been able to work in a high acuity environment with genuine pathology. That's really all that we're asking at this stage. In terms of the timeline for the Focus TOE logbook, it has to be completed within 15 months of your original registration. If you take longer than that, you do need to provide some level of justification, which often we do appropriate, because doing the TOE is obviously a little bit more logistically difficult than doing transthoracic. You have to be in the environments in which to perform these. So what I would suggest is, for those of you who are embarking on this in the future, do get in touch early if you're starting to get toward the sort of 10-month timeline and you're not really that far through your logbook. We can help you with extensions. And obviously, you'll need sign-off from your Focus TOE supervisor to make sure that they feel that you're competent to take the exam. The one thing that we do actually ask for with Focus TOE, and it's slightly different for HD, obviously Samson developed an electronic reporting form, which Ashley Miller, who is the National FUSIC HD lead, he has agreed that can be used as an alternative to the reporting sheet that was developed when we created the accreditation. For focused TOE, we do ask that you use the reporting template that was developed. Okay, that's really important, because what we don't want to do is flood you with the more advanced criteria that you often find on more generic focused TOE templates. So it's really important that you do stick to the template that was used within your logbook material. So pitfalls when it comes to logbook, just to sort of give you a really sort of simple example about what is good versus poor. Here's an example of what I would regard as a poor logbook entry when you're describing, for example, the LV function. Writing just LV function is normal with no measurements or supporting evidence or any detail. In fact, you know, that's really difficult as an examiner. We have really no idea about what that case looks like because we don't ask you to upload your images. So we need to know, did you measure that to qualify that particular description? Did you assess the regional wall motion abnormalities in addition to the global function? Did you acquire all of the adequate views that you needed to make that assessment? So this vagueness is not necessarily how we would expect you to report, because it could suggest that not much care has been taken when providing your report, or that you maybe have a lack of understanding about the metrics used to report upon. So contrast that with what I would regard as a sort of suitable entry. LV systolic function is significantly impaired, EF visually estimated at 25%, MAPC is 0.8, global hyperkinesis. What that tells me is that it tells me exactly what you found, exactly what metrics that you've used to quantify that, and then I can use those metrics to essentially compare against your qualitative descriptors to make sure that there's not discordance between the two. Other common rejection reasons include just missing measurements, incomplete view documentation. For the HD people in the room, we often find that the vexus section or the aortic section is not very complete. And what we end up finding out when we talk to the delegates is that, well, I had difficulty with that view, but obviously what we're not as examiners is, you know, we're not looking into the future and kind of sort of understanding what happened at that point. So we need to know why those things are missing, and it's completely reasonable if, for example, you know, the patient had a laparotomy and you found it really difficult to get good abdominal views, then you need to write that so that we can contextualize it. And I would say that for your cardiac views as well, you know, if you had issues with the quality, do actually summarize that in your particular conclusion. You know, I had relative difficulty finding a good apical window or apical windows, and therefore I wasn't able to really get a complete view of the regional wall motion abnormality assessment. I wasn't able to assess the ejection fraction suitably. That sort of extra little sentence on the end of your summary is really helpful, because it immediately makes me as an examiner, and I think my colleagues would say the same, it makes us know what the difference between somebody that's just listing a load of numbers and words versus someone that's really thinking hard about how to answer the clinical question. So those are little pitfalls that I think you should be aware of, because I think they're really helpful in terms of those of you who are going to do an exam potentially next year. So what are we looking for in the actual reports? As I said before, we review them often on the day, and we take about 15 minutes per logbook to obviously go through the whole 50 cases, or 30 if you've got prior accreditation. There must not be any patient identifiable information. That is a very generic requirement across any accreditation you ever do in echo. And if there is patient information on it, then it would potentially constitute a rejection of that logbook and a fail. So that's something to think about as a little cockpit check before you hand your logbook in. Just do a quick check to make sure there's no information on there. Second is measurement accuracy, and I've kind of alluded to this. So you use a lot of qualitative descriptors in your report, normal versus severely abnormal, and we ask you to obviously justify them using lots of different quantitative metrics, and those two things need to match. Okay, so if you've said a severely dilated left ventricle but your measurements are saying 5.2 centimeters, which is normal, there's clearly a disconnect there, and that will be something that we pick up on quite quickly. Third is clinical correlation. Ultimately, what separates these particular accreditations from standard BSc, EACVI accreditations is we're using them at the bedside and making decisions on that patient at the time. So actually the clinical correlation is very important, and it needs to shine through in your summary of your report. So do your findings look integrated to the clinical question? Have you taken a more holistic view of what's going on with the patient, rather than just list a series of isolated findings? We've talked about completeness already, so I won't go over that. And we've talked about case mix. But when I'm looking at somebody's logbook, I will flick through the summary first just to see what that general case mix looks like. And it will flag quite quickly if there's not much in terms of variation. So that's something that you could do as a last minute check before you hand it in. And then I guess the sixth bit that we do is just a timeline compliant. So it needs to fit within that sort of 12-month logbook collection, and that's something to be aware of. So when you're writing dates, just be aware of first and last scan fitting within that time frame. And I think what I'd like to say is the logbook itself, in the past, may have been looked at as more of a administrative kind of exercise, and for us, we do take it very seriously, because it really is the sort of first reflector of your clinical competence in this skill. So for us to entrust you and your clinical supervisor to tell us that you're ready for the exam is great, and we like to keep that sort of level of goodwill, which is why we don't ask you to give us video cases and whatnot that you'd see in more advanced accreditations. But what we do need from you is that a clean, precise logbook which shows that you are at the level that you need to be at. I think that's what I'd say. Just take a little bit of care with your logbooks, because it does say a lot about your competence before you even get near the probe. Right, that is your logbook sort of section done. Let's move on to the actual MCQ. And as I said, it's going to be single best answer format. So for the HD, this is approximation, guys, and I really want to stress that, because every exam we do, as examiners, we basically make potential changes to each exam to better them based on the performance of the previous cohort. So this is based on last year's exam, and I have spoken to the organisers, and not much changes have been made this year, but just take these as approximations as opposed to absolute numbers. So for HD, it's approximately a 30-minute exam, and you have 40 questions, and that might sound a lot for the duration, but if you think about it in this particular fashion, you have essentially projected ultrasound loops and images as almost a case, and then for each of those cases you will have 1 to 5 questions. Okay, they're very rapid fire, which is slightly different to the way that we conduct the Focus TOE MCQ. So the questions will be a mix of still images, cine loops, Doppler traces, and dynamic physiology. And essentially you're being tested on your ability to interpret these images in real time, just as you would if you were at the bedside. As I said, each slide will show 1 loop or still, and there'll be anywhere from 1 to 5 questions associated with that image or loop. And the questions are, again, single best answer with often 4 options. and they're designed to essentially test your interpretation skills, not your ability to memorize lots of different numbers. Conversely, the fTOE MCQ format is slightly different. So you'll have a longer exam, and you will complete around about 30 questions, which are longer in length. The questions are broken down into, broadly speaking, 2 categories. So 22 image interpretation questions, and then a small amount of fTOE theory questions toward the end of the exam. Again, the sort of image interpretation questions will show you the video loops and ask you to identify pathology, for you to quantify based on the measurements that are put in front of you, and then to determine the clinical significance of these. So they are very similar to the HD questions, but they're more in depth, hence why they've got a longer time to answer. Obviously, the difference is in this exam, you've got more theory toward the end, and this will assess only the theory that is included in the syllabus. Okay, so that should give you a good sort of idea about what type of questions. We might ask you stuff about clinical governance, safety, technical knowledge around fTOE because of the additional risks that are associated with it. If you want to refer back to your training handbooks for the syllabus for both these exams, that will be a good start when it comes to preparing for this content. There is a little bit of strategy that you can apply to these MCQs. Make sure that you practice rapid image interpretation, particularly for HD, because you've got shorter time to answer the questions. You need to be able to look at a loop within a few seconds, really, up to 45, let's say, for example. And you need to identify what the view is, spot the abnormality, and formulate a differential. And that speed, as you know, as clinicians, comes from pattern recognition. So it's important that you expose yourself where possible to lots of this. Second, you need to know your normal ranges. Really, really important. So if you're second guessing at this point now whether the TR velocity of 3.2 meters per second suggests pulmonary hypertension or not, then that's something you need to sharpen up on before the exam. Okay, so you should be able to know that 2.9 to 3.4 is intermediate probability, and anything above 3.4 is high. That's the sort of level of instant recall that you need for this particular exam. Third, understand the physiology behind the findings, which should be, you know, relatively easy for most of you because of the areas that you work in. It's not just about pattern recognition. So, for example, you know, when you're talking about why systolic flow reversal in the hepatic veins indicates severe TR, you'll be able to reason your way through unfamiliar scenarios, for example. During the exam, what we need to do is answer what you know pretty immediately, which I think is a strategy that you're all probably familiar with. If you see a question and you're confident in the answer, just go for it because it's probably right. And actually then you can dedicate the rest of the time to looking back through any potential questions that you're not sure about, or dedicate the time to the next question. Don't second guess yourself. Often your immediate recall is the right answer. If you're uncertain about things, do just flag the question mentally and come back to it when you've got more time. Trust your clinical instinct. Again, I think that kind of comes back to that instant recall thing. So even if you're unfamiliar with the echocardiographic features, you can often reason your way through the question based on your ability to understand the physiology. And always watch out for the tricky phrasing. So, for example, questions that say which of these is least likely, or all of the following except. Those are questions that we're not designing them to trick you, but you do need to read the question a lot in terms, try not to get caught out by those who potentially would skim read a question. And all of that really constitutes a framework which I would suggest that you apply to every single question that you come across. So identify the view as step number 1. Which orientation are you looking at? Which structures should be visible? Do a quick assessment of the quality. Is it good enough for you to be able to say, I know what the question and answer is? is there artifact that might be sort of playing here in your favor or against your favor, or is there poor visualization that kind of renders this image quite difficult to interpret? Although that said, we're not going to be giving you images that are not diagnostic for the obvious reasons. Step 3, spot the abnormality as quickly as you can. What doesn't look right? Even if you can't describe it, what just doesn't look right? Is there a dilated chamber? Is there abnormal motion, abnormal flow, or something else? Step 4, apply the physiology. Why does this happen? What's the underlying mechanism? And then step 6, eliminate I've gone over correlating clinically. Does this finding that you've identified at this point fit the clinical scenario? Because often at the beginning of the question, you'll get a scenario or a few sentences worth of context. Does what you now think is happening fit that clinical scenario? And then finally, eliminate the implausible. And it may be you want to do this immediately, but often I think reasoning your way through it first is sensible, and then eliminate the implausible. So let's apply that to a couple of examples, and I'll only give you 2 because I'm conscious of how similar exam questions might actually be. None of these have been used in the exam, I can assure you of that, because they're from my own logbook. So the following wall motion pattern is most consistent with which of the following? So the scenario that you've got here is that the patient has got chest pain, elevation in the 2, 3 and AVF. And then you've got your image here, which I'll just give you a minute to look at. And then we'll just flick on to the stepwise kind of framework. So what we can identify very quickly, it's a parasternal short axis view, transthoracic. We can see all of the left ventricle in cross section, and we can see a little bit of the right ventricle wrapping around anteriorly. And in this view, we know this to be a view that we can see all 3 coronary territories. Step 2, the image quality, looking back at it, pretty good. It's not diagnostic. So for me, it's diagnostic or it's not. And we can see the myocardial walls very clearly in order to make an assessment of regional wall motion abnormality. Step 3, spot the abnormality. Well, if we look back at the image here, and hopefully you can see my little pointer, all walls seem to be thickening until we get to this particular segment here, which by now you should all know to be infraseptal inferior wall. Okay, predominantly it's the inferior wall, and importantly, it is not thickening and it's not moving centrally as the rest of the walls are. Applying the physiology, we know the ECG findings are correlating with the RCA territory, and we know now that the inferior wall correlates with the RCA territory. So we are unable, even by that point, without even looking at the implausible, we can now pretty much tell that this is consistent with what is question number D, inferior wall hyperkinesis, although I would argue that that's actually akinetic, not hyperkinetic. So just to complete that framework, the implausible options here are A and C, where it talks about left-sided supply, which clearly wouldn't correlate with the inferior ST elevation that we saw. And then option B showed global reduction, which would suggest a more diffuse process as opposed to a regional process as we've seen here. So that's how you would reason your way through an MCQ. I appreciate you've got very little time to do that, but I'm taking on board that most of you that are at this level now would probably be able to do this very confidently. And for those of you who are in the room that are doing your focused TOE, then again, this would be a sort of routine question. You've got a mid-esophageal 3-chamber view. Which of the following mitral valve abnormalities is most consistent with this finding? And as you can see here, the options are anterior mitral valve flail, posterior mitral valve prolapse with anterior directed regurg, mitral annular calcification with central regurg, and cystitis or SAM with outflow tract obstruction. So having a look at the little image in the top right hand side, by now we probably will have reached up to a minute, although this will be playing the whole time that you're able to look at the questions, so it's a bit unrealistic in terms of what I'm showing you now. But if we then work through looking at what we're seeing here, we've got an image of a mid-esophageal long axis. The image quality is good. I can see everything that I need to see in order to make this diagnosis. I've got a mitral valve anterior leaflet and posterior leaflet here, and it does appear as though the posterior leaflet is prolapsing back into the left atrium, and as a result I've got a very, very, very large eccentric anteriorly directed jet which is wrapping around the whole of the left atrium, which the left atrium is large. Lots of mosaicing, which shows high velocity of flow. So that sort of essentially outlines the whole reasoning process from start to finish. And I appreciate that actually, in reality, if we're showing you a picture like this, we'd probably side by side show you one that hasn't got colour on, just so you can identify that very clear mitral valve prolapse here. It's not a flail because it wouldn't show the pattern in which we're seeing in terms of the direction of the jet. If it was a flail of the anterior leaflet, we would often see a posteriorly directed jet, which is obviously the opposite of what we're seeing. There's no calcification noted at the annulus of the valve, and the jet is not central, and there's no evidence of SAM, which again, just to draw your attention, we're not really focusing on the alveoli at this stage, and there's no obvious AR or decreased diameter between the anterior leaflet and the septal wall. So that's how you would reason through your MCQ in the event that you don't know what the answer is immediately by looking at the image. Right, moving on to the practical. Where are we with time? There I am saying I won't rabbit on for the hour. Practical exam, HD. So broadly speaking, you will have around about 30 minutes to scan a live model. You'll be expected to acquire a predefined number of views, because if we were to ask you to do the whole data set, you would be there for a long time because it's an extensive data set. So we as examiners will predefine the views, and you will be asked to acquire that specific view. You'll be asked to perform measurements as you go along, and you will be asked to optimize image quality in real time. We want to say that you're demonstrating appropriate Doppler settings, and we want you to respond to our cues. I'll talk to you about cues in a moment. I don't think I need to tell anyone about professional conduct, but that's something that is obviously taken into consideration when we're watching you in your exam. The scoring scheme is pretty standard. So for HD, 0 is that you've not been able to achieve the view, or the view was obtained but not optimized. For partially and for achieved, we give you a 2, and that's when you've achieved the view and you've optimized it and all the measurements are accurate. The overall pass threshold is about 80%. Anything below 70% is a clear fail. If there's a borderline, score, then we often involve an additional examiner, so that we can review your performance. You may be asked to perform something again if you're at the very borderline, because clearly we want to make sure that we pass people that we're not entirely sure about. For practical exam for focused TOE, the only difference is that you are expected to do the full data set, because there's only 8 views. So we won't be prompting you on what those views are. So we will expect you to remember what that data set looks like and to just continue with it. Comment on findings as you scan them. There was always some guidance around presenting a final report, but it is going to be a normal scan. So, you can just summarize at the end, this was a normal study with no pathology detected. We will be looking at probe handling more specifically, because clearly this is part and parcel of our checks of that you're a safe practitioner. And again, we're looking at all of the normal stuff. Are you optimizing your depth, gain and focus? And are you able to interpret findings accurately? The scoring scheme is slightly different. It's a 12-point scheme, and it covers your ability to set up for the scan, your views and the interpretation with your oral report at the end. So if you're working on 8 views over 20 minutes, then you've got about 2.5 minutes to perfect each view, which I think is appropriate, given that clearly there is a slight complexity to focus TOE in contrast to transthoracic. So what are we looking for both of the practical exams? Well, essentially, it's beyond just technical proficiency. Clearly, we want you to be proficient technically, but we will be able to see whether or not you can acquire the views, and we want to know that you can take accurate measurements. But what we're really assessing is your ability to perform it safely and effectively within a sort of faux environment that you'll be set up on the day. We want you to apply a systematic approach, as most people that work in a clinical setting that's acute or critical. We want you to be systematic about your approach so that we know that you're not missing out on crucial data. Are you working through the views in a logical order? For those of you doing focus TOE, where you're let to do the data set without prompting, or are you just randomly hunting around for images? We're looking for real-time optimization. I can't stress to you enough that it's really important that you adjust your depth, gain and focus as you scan, rather than just settling for what's in front of you. If you, for example, focus TOE, we tend to position the simulator such that your actual monitor is furthest away from you, so you can actually ask the examiner that's in the room, can you increase the depth, can you decrease the depth? That's how it tends to work. We're looking for you to be verbal, and what I mean by that is talk out loud. It's really, really useful, because if you're struggling with a view, but you're saying that you're struggling with it and you're trying to give me some clues as to what you're doing in order to try and optimize that view, you still may get points for that attempt, okay? Because I can tell in reality, it can be quite difficult to obtain views, even in models that have really nice views, after lunch, potentially when they've had something to eat, if you're trying to get Vexus and they might have a bit of bowel gas. So do talk out loud. Recognition and correction of errors. If you have made an error, then just be transparent and say, I'd like to do that again. That's really important. And safe, deliberate probe manipulation. That goes for transthoracic and TOE. So, it's quite a tell, and I think you guys in the room are probably aware, because you've been scanning long enough to know that if someone is sort of manically trying to look for an image with erratic probe movement, it does tend to make you feel like they're not very experienced, and we feel that way as examiners. So just be very sort of safe and deliberate with your probe manipulation, particularly those who are doing TOE. I know it's a simulator, but we're essentially trying to assume that you're doing that on a human. So be very, very deliberate with your advancing and your withdrawing. And most of all, we want you to be clear on your integration clinically. What are red flags? Well, for me, red flags would be that you completely silent throughout the whole exam, because I don't know what you're thinking then. Just be, like I said, verbal, talk out loud. Even if you're not finding anything difficult, it's really nice for you to say, right, I'm getting the parasternal long axis view, I can see everything in the sector. Maybe I can't see it very well, so I'm just going to move the probe around the chest a little bit. Poor time management, and what I mean by that is if you literally get fixated on one view and want to perfect it, you've got to be aware that there's only a finite time for you to demonstrate as much of the data set as you possibly can, and you will lose points if you don't try and limit your time spent per view. If we're giving you lots of prompts and you fail to listen to us, then that is a bit of a red flag. So do listen to what we're saying, because we often only speak when we're trying to help you. Clearly unsafe technique, that's a given. And if we ask you when you've obtained a measurement to maybe interpret that and you're not able to do that, that's obviously a red flag for us. There are a couple of micro behaviours that I would pass on to you as tips. Some of them you will obviously have already picked up on from the past few slides. If you talk out loud constantly, within reason, obviously, I like that as an examiner because I can tell what you're thinking. Again, try and limit the amount of frantic sort of probe movements that you make. Every time you go to a new window, just relentlessly optimize your depth gain and focus, even if you don't feel like it really needs it. That kind of mental note that you're taking every time you're changing view is really important, because it shows us that you are understanding the physics behind ultrasound. So that is a really important thing to do. I've talked about cues. If we hint something, and I think there's a slide on the sort of common things that we might say, listen and try and action that quite quickly, because we're doing it for a reason. Move strategically on, so don't fixate on one view. And if you do find that you've really not got the view that you want in terms of quality, just tell us and say why you think that might be. And stay calm. You know, I know that this is a exam setting. You've got two people watching you perform, and even if you feel quite confident in your practice, it is an unusual setting. We expect that. We take it into account. Okay. Time discipline. There's a slight difference between the two, because obviously for the 8 views, you are given a slightly shorter time, and it is around about 2.5 minutes per view, which would be helpful for the guys that are doing focused TOE to prepare, maybe time yourself to that average. For HD, we tend to stick to around about 20 minutes for the cardiac component, and then the remaining time is for Vexus. So overall, it's 30 minutes. And we've never really found that people run out of time. Have we got a hand up, Simon?
That'll be me. Just let you know, we've got about 8 minutes left on the call.
That's lovely. Perfect. We're coming toward the end, and I can then say that I have been disciplined with my own time. Prompts are not punishments, so don't take it offensively if we prompt a lot. It's not because you're doing something bad, it's just we're trying to help you get that extra point. So if we say, how's your depth or something like that, then just adjust it, okay? Because it's wrong. That's why we're saying it. If you're are you happy with that measurement, is often because we're not happy with it and we want you to recognize it's not right. So redo it, okay? We're never going to ask you to redo something, or we're not planting seeds of doubt in your mind. If something is correct, we just accept it. So if we're asking you to consider if you're happy with something, then we're often doing it because it's not correct and we want you to redo it. Can you optimize that further? We often see something that you're not seeing, so just be critical of what you're looking at and just think, have I not got the depth where it needs to be? If I say, tell me what you're doing, it's because you're not talking out loud like I'm suggesting, and actually it's really helpful for me to kind of understand what's going through your mind. And if we say move on to the next view, it's because we're trying to manage your time so that you can get those last minute points. I'll come to your question at the end, Mohammed. Practical exam pitfalls, well, they really broadly speaking fit into these sort of 3 bits really. So predominantly it's going to be image acquisition, because that's what we're measuring you on. So foreshortened views is something that comes up a lot, and that's within standard practice. So that is often because your probe is too high up on the chest for those who are doing HD. So try and move down and optimize that. Often when we're asking you to do the Doppler measurements, if your angle alignment is off, that's a really common thing. So just make sure you're parallel to the direction of flow. Gain is endemic. Just try and make sure you take some time to do your gain above everything else, because we find that people don't optimize their gain as much as they should. And the other thing is incorrect timing. So if we're asking you to measure the LV and end diastole, make sure that you're at end diastole either by the ECG or the mechanical points. Conduct, we talked about silences. No one has ever been rude, but it's just to say that if we are prompting you a lot, try not to take it defensively. We're trying to help you. And things like rushing through the optimization, these are things that you need to take time with, because it can improve your performances. And then time management is a big thing. You know, we need to get you through the scan as quickly as possible, so we will help you with managing your time. So last couple of slides, what you can do now is, well, in the final weeks that you've got, there's two types of activities. One will not help you at all, one will help you significantly. If you are doing either exam and you've got a simulator, this is going to be really good for you to practice with a timer, particularly for those who are doing focused TOE, because you've got a finite number of views. Make sure that you fit within that 20-minute time frame per 8 views. Okay, for those who are doing FUSIC HD, you want to get most of your cardiac data set done, and we'll ask you to do all of the VEXUS data set. Okay, and that's got to be within the 30-minute time frame. Go back through your own logbook and see what patterns exist. Where did you miss out on measurements because they weren't up to standard, for example, and then focus on those particular parts when you're looking at revision, for example, or looking at practical skills. If you've got the ability to download a lot of your loops that you've used toward these cases, maybe put together some practice MCQs for yourself so you can do some rapid fire interpretation. That's really helpful. And when you're doing your practice, whether that's on a human or a simulator, talk out loud to a colleague, because it's really helpful. And I think it's a really good skill for when you become a trainer yourself, which a lot of you probably are FUSIC mentors already. But when you become a FUSIC HD trainer, you know, these are the skills that you need. Talk out loud as you're scanning, and that will be helpful for us as examiners. Look at your normal ranges, look at your key measurements. What I don't think you should do is start looking at textbooks at this point. That's not going to help you. The syllabus is pretty straightforward, and you will, by this point, know it. It's just about refreshing yourself on the syllabus. Don't necessarily watch loads of YouTube videos, because they're not all peer-reviewed. Some of them don't follow the BSE guidelines, which is the guidelines that we are adopting within most of the data sets that we're using. Don't start to learn new pathology outside of the data sets that you've been given, because it's not going to come up on the exam. We don't inject zebra pathology. It's pretty much the horse stuff. You can be sure of that. And don't obsess over any rare diagnoses. Exam day, by certainly, hopefully within the next week or so, you will get an email detailing the schedule of the day. I know the Focus TOE schedule has been written. The Focus FUSIC HD schedule is being confirmed tomorrow, I believe. There will be AM and PM slots, okay, because there are a lot of you this year. So you'll be given an AM or a PM slot. The MCQ will be a group sit-in, and the individual practical exam will be conducted obviously individually, but you'll be brought through in pairs, because there'll be 2 sets of exams running at once, separated by a sort of screen, as you would if you were doing any of your medical exams. The logbook review will either happen prior to the exam, or it will happen when you're doing your MCQ. You won't be given the results of anything until the end of the day, so you're not going to find out you've not passed one station before you then have to go and do another. We don't want to affect your performance in that way. As I said, results will likely be given on the day, and I've said likely because there is quite a lot of you, so we do need to give ourselves the time to get through all of your logbooks. So hopefully we can tell you on the day, but I don't want to say definitively that will happen. You will only expect to sit or resit the component in which you've failed, okay? and you will get 1 attempt for that, dependent on the severity of that fail. Borderline cases will always go through a reviewing by a 2nd or even 3rd examiner, and if there is discordance between examiners, then the lead examiner will take point with regards to the outcome. Trust the process. Everything we've done has been a refinement of previous exams, and we hope that we've got to a point now where it's going to run relatively smoothly. Last year ran very smoothly. I'm not anticipating any issues at this point. And I guess the final message is good luck, because you have definitely got this at this point in your process. So it's just a case of showcasing that on the day. And I, for one, am looking forward to meeting those of you who are due to attend. So I know we've kind of come up to time. I didn't expect that, actually, but I will want to answer some of the questions that you have put forward